Hello, my name is Stefan Specht. I'm the clinical marketing specialist for DXR for image quality, and I would like to talk today about what's happening in the background when, for example, a digital diagnost is being used and an image is produced. First, I would like to come to the analogy of analog film that we used before. What you see here is that we have three main boxes. What happens in the background or in the foreground when you expose a film. First of all, we have to set the technique, like KV, dose, are we using a grid, what about positioning the patient correctly, and so on. This is the technique part of the image chain when we use a normal film. We are exposing a film then, and this film is afterwards developed either with wet chemistry or as a dry film. If we take this analogy and now go to the next technology, which used to be CR, what can be seen clearly is that the technique part did not change. That means still on CR there was the need of setting the right technique, the right dose, the proper grid, and so on. Nothing changed in this area. Now instead of a film we have the image plate that we expose. This image plate needs to go into a reader, which creates quite a long workflow. Afterwards, also in CR, we used to have image processing, which happened in the background. On our latest PCR Eleva, this is already our unique image processing that we now also know from DR technology, and afterwards this image is sent to a PAX or to a film. The image processing in PCR or in CR happens automatically in the background. The user doesn't have to do anything about this. Here are some pictures of early systems. This upper picture shows a CR image from Philips from the beginning of the 80s, and some other pictures show how the readers evolved and how they get smaller and better. Coming to DR, still we have the same thing about the technique setting, and here we clearly see whatever media we are exposing on, basic X-ray physics did not change and does not change. Still, the operator needs to know what KV should be used, what dose, what about the grid, and so on. So it's very important to know that basic X-ray technique has no change between film and DR, except the dose, which can be lower of course, but still this is an important part. After that, the image goes into two processes that happen in the background of an Eleva system, which is first the ranger, we talk about this later, and the image processing, that is our proven unique image processing. Both processes happen in the background. And afterwards, like CR, the image is being sent to PAX or is being printed on a laser film. Here we see some early DR systems from the beginning of the 90s. We see wall stands, tables, the Bucky table, and this was how it started with digital diagnost in the mid of the 90s roundabout. And now I would like to show you what happens in the background if the operator presses the X-ray button and an image is produced. This is the image chain in a technical overview. We have the technology or the technique that goes into the detector. We have the detector itself, we have pre-processing, post-processing, and we have the export. First, what happens here, even before the image reaches the detector, we talked about this, the technique needs to be set, the right KV, the right dose needs to be chosen, and the patient needs to be positioned, of course. Then here we see how it looks like. We have basically two different generator types in the field for DR, which is the separate generator board for non-integrated systems and the integrated generator board, for example, for our high-end digital diagnost system. Both have the same function. The only difference is really that the generator board is not separate anymore if you have a digital diagnost. Summer comfort is built into this integrated generator, and we come to this later. This is one of the points that is outstanding on the integrated generator. An important point to mention is that we have 7 patient types that the operator can pick from, and by picking one of these patient types, the technique factors are set and the image processing is being changed accordingly. The 3 settings for child, baby and newborn are being set automatically by the system if the RIS sends the DICOM element for birth date, in which case Eleva will calculate the age and will set one of these 3 patient types automatically. Coming to grids, we see that in DR technology, as in CR and conventional, a grid is being used for reducing the scatter. In DR technology, this grid on our Bucky TH table, for example, this grid is oscillating, and on other systems we have non-oscillating grids, because sometimes the space in the room for an oscillating mechanics is not or difficult to implement. Those grids that are not oscillating, in these cases the grid lines are being removed by a software in our DR technology. Oscillating grids, they can be low frequency grids, and because the grid is moving during the examination, the grid lines are not visible. We have non-oscillating grids in some configurations where now in DR technology we can remove the grid line visibility by software. And the latest technology is SkyFlow, where we even don't have to use a grid anymore. In SkyFlow, which is available at the moment for portable chest examination, is using a skyplate detector, and the skyplate detector can be used without grid during the examination. SkyFlow is a technology for DR which removes the scatter from the image by software. That means we don't need a grid anymore. The workflow is much faster, and the image quality that the radiologist is seeing is showing a contrast as if a grid was used. So SkyFlow includes the benefits of both worlds: workflow without grid, image quality as if the contrast of a grid was reached. Very nice technology. It is available at the moment for portable chest with skyplate detectors, and very soon we will have SkyFlow also for other anatomies outside chest if the image is being acquired on a portable detector. Coming now to detectors itself, this is the first step in our image chain. Detectors could be a PCR plate, could be the fixed 4600 detectors, could be the sky plate. All detectors are being adapted by our detector software. What happens here? We have different detectors available for DR technology. For example, here the fixed detector in a wall stand, here the fixed detector in a wall stand for the VM, for the flex room, here the fixed detector in the Bucky tray of a Bucky TH, and of course here the skyplate detectors, our latest technology. These are DR detectors with the size of a conventional CR plate, of a CR cassette. We have them in 2 sizes. All these detectors have a certain amount of technical data, of which I would like to come and talk about some of these. Number 1 is the bit depth. We know that our detectors supply 14, 15 or 16 bit depending on the type. Now what does bit depth mean? It means how many gray levels for each pixel are supplied. Here is an example of only 8 bit. We see 256 gray levels. This is an equivalent for 8 bit. You see the image is quite decent already. Now imagine we have 14 bit, which would supply a number of gray levels of around 16,000. What happens if the number of gray levels is not sufficient? You see it on the right picture. Only 6 gray levels, and then it's very visible that this image is not sufficient. Or on a medical image, we have 8-bit, 3-bit, 2-bit and 4-bit, and the absolute minimum to see something for on a medical image is really 8-bit, but still this is not state of the art, and 14 to 16-bit is what you should see. Here is the resolution. We are seeing here now a matrix of 512 by 512 pixels in this image. If the resolution is not enough, like on the right side where we only have 64 by 64 pixels, you see this pixelation effect. This is very known from digital cameras. Our detectors supply up to 9 million pixels, so like 3000 by 3000 pixels. The next property is noise. Noise is an image property that goes with different parameters in DR. Mostly, I would say they are influenced by the dose that you apply. And here we are back again to the discussion of technique settings that are still applying also on DR. So we need to find the right dose to create the right image impression in terms of noise. But also very important is that the receptor, so the detector, has a certain quality, a certain sensitivity. This is given by something that is called DQE, detective quantum efficiency, and these two things together create a certain noise impression in the image. Here you see what happens if we change the dose from very high to normal and to too low, and the noise impression is higher on the image that has a lower dose. Now the question is, of course, and customers ask us this all the time, what dose does a DR system need now? What does Philips recommend? And this is different from film. On film we had a certain dose that had to be followed. In DR technology the degree of freedom is much higher, and basically a lot of different dose levels could be applied and still the image would be very nice. So our answer is, we cannot tell the customer exactly what dose they should use. We have a factory set which works very nicely on a normal dose level, but here the customer has the freedom to change any other dose level that is appropriate for the purpose of this image. So very important to understand, the dose in DR is not fixed. It's really a dose that belongs to the customer, and they are responsible to find the right dose for their question and for their purpose. Here's an example. This is conventional film, where you see on a normal dose we have a certain value of contrast and brightness. On film, what happened if the dose got lower is that the film gets more bright, underexposed, and if the dose was too high, the film gets darker, overexposed. On DR technology this does not happen anymore. On DR technology every dose level creates the same contrast and brightness impression. What changes on DR is the noise level depending on the dose, and the noise is too high if in white areas like here the noise gets too high for the radiologist, and he would say something like the image is too grainy. Also the dose can be too high, and we come to this discussion in a minute. This is a curve that is called NEQ curve. It shows what happens to a detector in terms of signal to noise ratio over dose. So here we see on the horizontal line we can see the dose, on the vertical line we have a measurement for, so to say, image quality in terms of how grainy, how noisy is the image. The higher the better. The green curves describe what happens on conventional film. What happens on conventional film is that on a certain given dose there is exactly one optimal point in which this film will deliver a good image quality in terms of signal to noise. If we don't use this dose but we underexpose, the curve goes down rapidly because the film gets too white and there is no information left. The same happens if the dose is too high. We see the curve goes down immediately because the film gets black. So on film there was only one dose that was good, there was no other choice. Or we take a different film type, like this one, where this film needs more dose, as we can see, to find the optimal point, but for this more in dose we are getting a higher signal to noise ratio, so this film will deliver a better image quality in terms of sharpness or noise, but the price that we have to pay is much more dose. Many years ago CR technology was introduced. The big difference between film and CR is and was that the behavior of this curve is linear. This curve is not falling down as rapidly as a film if the dose was getting lower or higher. We call this a linear behavior, and this means over or underexposure, like a film showed, is not possible on on CR. Every dose level will create an image. Of course, what applies is really if the dose is too low on CR, the noise level is too high, and this might not be sufficient because the image looks too grainy. This was a very big benefit of CR, the linear behavior, but still what we see is that sometimes the image quality of a film is better on a given dose compared to CR, and it was very clear CR has benefits, but it does not save dose for the patient. In principle, not. Now the blue curve is DR, and here you see a typical DR detector is also linear, and it's better all the time. That means the big benefit of DR, except the workflow, which is also much better of course, is that on a given dose the image quality is always better compared to film or CR. And here again we cannot answer the question distinctly what dose does a DR system need, because any point of this curve would be possible. This is how the system comes from the factory. This is our factory preset, which is a normal dose setting like a 400 film speed film, but now we are supplying a much better image quality. So we win this image quality when a system is shipped from the factory, because we are still on the same dose level compared to a 400 film speed combination. This is the starting point. The customer can use this and will have success with image quality, and maybe there is no need for changing that. But of course some hospitals would like to save dose. We have pediatric hospitals, we have special questions on follow-up studies where people would really like to save dose, in which case the customer could tell us to do that. What we see here is that we are not supplying a better image quality compared to a film now. The image quality in terms of signal to noise is the same, but this on a much lower dose level. So we could say these 2 points are 2 distinct points that are quite typical, and we could adapt to that. Our service, our application will do that. Strictly speaking, any point of the curve is possible. We could say, for example, what a digital diagnost or a DR system from Philips can do is, for normal questions, supply a normal dose, but for special questions we could go down with the dose or go up with the dose, depending on special needs for this particular case that a radiologist would like to see. Pediatric questions could be located down here, follow-up studies as well, where a higher noise level could be tolerated, and higher dose could be required if very, very fine and very super sharp structures needs to be seen. So one system in one room could supply different dose levels depending on the question. This is possible in DR, which is a big benefit and a big degree of freedom, but also it gives the responsibility to the customer what to do about dose. Also, a DR system has its limits. We cannot go very high and we cannot go very low. At the very outer edges of this curve, of course, also limits will happen. Here is one limit, which is the dose was too low, much too low, in which case the image is really too noisy, and this would not be a case that we could use, and this image would have to repeat it. On the other hand, we have this. Here we see a real image that happened in a customer site where somebody produced a dose that was more than 10 times too high. This is really an operator error, and what we see here is that we have effect that we call burnout. Here the detector was in overflow. It's like the digital camera. If you would like to make a photo of the bright sun, it will not be possible because also our sensors in digital cameras have a limit over which we have overflow, and this is a very good analogy to DR technology. We have tools that would warn the operator, the exposure index, where I will be coming to later. Obviously in this case the operator didn't care about the exposure index, didn't care about the dose, and then this happens. In the normal range, here we see what could happen, and here we see what a normal setting would be in a very successful way. You see a hand phantom X-ray with a normal dose. In this case, with normal image processing as we supply it from the factory, giving a normal sharpness, we have a certain noise level and we have a certain detail visibility in terms of sharpness. This is in balance, so this dose, a normal dose, works very nicely with the normal sharpness of the image. If the customer would tell us they need much more sharpness, I simulated this and call this super sharpness. In this case, we see an increase of noise, of course, but also a very much high increase of sharpness in the image. If this noise level is being acceptable, depends on the particular radiologist. We cannot answer that question really, but here the responsibility of the customer steps in, and they have to tell us, is this enough dose for this kind of sharpness, or do we have to have less sharpness or more dose, or is this okay? What DR offers us is now also a different dose level as we understood. So here I supplied only 25% of the original dose, really low now. In the overview we don't see much of a difference. Also for the normal sharpness impression, this is still a noise level that might be tolerated by some radiologists. Here this is a question of discussion. This would save of course a lot of dose if normal sharpness is enough. On the other hand, if we would do super sharpness on this very low dose image, I'm guessing that most of the radiologists would say this is too noisy now, and the combination of super sharpness and very low dose is a combination that might not work. To do this even further, here we are down to 10% of the normal dose, and here even the normal sharpness might be too noisy. On the other hand, some specific questions might allow us to do that if the radiologist knows that there is a higher noise level but the patient dose is so much lower. Especially in pediatric cases, I can imagine that sometimes this would be very sufficient. Super sharpness on super low dose, this is a combination that will not work. On the other side, here we see an image with 3 times of the normal dose, so a very high dose, much too high. And what we see is that for normal sharpness, this dose is not required. This image is extremely noise free. And remember, this is a phantom, not a real live hand, not a real human hand, where you would see structures in here that we don't see in our phantom. And this means that this noise level is too low for the question. So this is really wasted dose, I would call it. For this kind of sharpness, we don't need that much of a dose. And here I would really say too much dose was applied and it would not have been required. For super sharpness, the things might be different. If a radiologist really wants a very, very sharp image, then maybe 3 times the dose is not too much. This is really a question that has to be discussed. To look at the same pictures the other way around, here you see for a normal sharpness we have different dose levels, and now the customer could pick what is appropriate for them. I would say normally for a normal sharpness processing we will find ourselves somewhere between normal dose and a quarter dose, maybe on half dose, which would be much lower than any film or CR could offer. For super sharpness, the noise level is always higher because of the higher sharpness, and here maybe we will find ourselves being between normal dose and 3 times the dose to make the image noise free for this kind of high sharpness. So, very important to understand, the question to the customer is not what dose does the system need, but the question is, what dose do you see, dear customer, what dose do you see to be correct for your question and your purpose. This discussion about dose is always a discussion that cannot be done alone, as you saw it from the phantom images. This triangle needs to be in balance. The dose and the image processing and the perception of the viewer need to be in balance. If we would just reduce the dose without talking to anybody, without changing image processing, this triangle would go out of balance, and either the radiologist would complain about a noise level that is too high, or he would tell us to modify the image processing to give less sharpness. So whenever we change one of these 3 circles, we have to at least work on another one to keep this triangle balanced. If we want to reduce dose, we have to go to the radiologist and see, look, your images will be more noisy, is this okay for you or not? If it's okay, it's fine. If it's not, we have to go to image processing and change something there. Or if the customer tells us, I need sharper images, we can give him sharper images by image processing, but then we would have to have a discussion about noise. If the noise impression in this sharper image is okay, we are fine. If not, we have to change the dose at the same time. Let's come to pre-processing. Very short words about pre-processing. This is a process in the background that cannot be influenced by application from Philips, and also of course not by the customer. This is the detector calibration that is applied to every image. So whenever the customer does a detector calibration, this pre-processing is being filled with new data, and every time an image goes into this pipeline, this pre-processing containing the latest calibration information will be applied. After that, the image looks like this. This is an unprocessed pre-image, how we call it. Unique did not work on this yet. This image is very flat because it shows all the gray levels, which can be up to 64,000 gray levels if we have a 16-bit detector. And to display them on a display, the image will look very flat. This is not an image that we should show anywhere. That means now we have to apply image processing. Image processing is our unique image processing, and it's located in the process of post-processing in the image chain. Why do we need image processing anyway? We saw this raw image and we know why this is very much required. Again, it is because our detectors supply much more gray levels than a normal display could handle. Good displays today supply 8 or 10 bit, but our detectors, even a CR plate from Philips PCR Eleva, supplies 12 bit, which is more than 4,000 gray levels. Our best detector supplies 16 bit, which is like 64,000 gray levels. So we have to do something to bridge this bottleneck. In other words, a good DR detector would supply 64,000 gray levels from very white to very black. And if we would not have image processing, we could only view a part of it. With a normal window and level operation, without image processing, we could, for example, window into this area of the image. Then we would see the white area of the image in full resolution, gray level wise. But from here to black, everything would be completely black and we would not see anything. So we can move the window from here to there or to here, and we would only see always a small portion of the gray levels in full beauty. Or we could compress and really not use a lot of gray levels. This would be called compression or having a low contrast in the image. This happens also in photography. I would like to show this picture now. This is a raw image taken with my camera without any image processing. We see, for example, that we don't really know if this area is completely white because I'm applying the wrong window level or because the detector was in saturation. We don't know. And also here in the black area we are lacking information. The image is too black and we don't see much here. If I would now window only with a linear operation into the white area without image processing, this would happen. We can now see the brighter area of the image much better. We see that we cannot recover this area because this area is now completely white clipped by detector clipping, like the sun. But the rest of this bright part in the image is very nicely visible. But the price that we pay is that everything else is completely black. If we would now move our window into the black area, we see all the information that we could not see in the black area before. So the darker area of the image is nice, but now the price that we have to pay is that in the white areas there is nothing to see anymore. This would be compressing. Now we see that we really threw away gray levels. There is no clipping. We see every detail, but this is not a nice image. It's much too flat, it's much too gray, and nobody would like to use this one. This is again the raw image. If I apply image processing now to this picture, it would look like this, and the benefit is now really visible. We see all the details in one picture. We don't have to window, it's all in this picture. The information in black as well as the information in white, or in bright in this case. That's the purpose of image processing, to show everything that the image offers in one picture and not having to move any window and level settings around. We can also over-process and do more than we should, like here. On a picture like this it doesn't really hurt, but on a medical picture this over-processing include some dangers. Here for example we see a black artifact. If I go now to the raw image, this does not exist. So what we see here is we introduced an artifact in the image that didn't exist, and this is just an image processing artifact. The same here, where we see a brownish frame between the white area here and the sand here. This brownish frame is called edge artifact. It does not exist in the raw image as we see it, and this is an artifact that is quite dangerous in medical images. Coming back to medical images, here we see an unprocessed image. What we see is that the details are quite visible in this area, but because of that high contrast giving us these details, we are missing the soft tissue as well as the nasal bone. If we compress, or if we apply a low gamma, a wide latitude, we could say, we are getting the information back in the soft tissue. We are seeing the nasal bone, but now we are missing the details here. So both is not really what we want. What unique image processing offers now is that we see both in one picture as we see it now. The details are there, but also the soft tissue is there, the nasal bone is there, so this image shows everything that this image has to offer in one go, without any need for moving any mouse and any window level. Image processing in DR, our unique image processing, is much more than that though, and I would like to come now a little bit more in detail to what image processing does for us. It comes in 3 steps. Step number 1 is ranging. You will find also sometimes the expression segmentation. Step number 1. Step number 2 is brightness and contrast. In our terminology we call it density and gamma. And number 3 is, what about details? What about the sharpness of details, super sharp, normal sharpness? This is step number 3. Step number 1 again is the ranger. The ranger answers the question where in the image is region of interest, ROI, the interesting part in the image. This is a picture visualizing this. In a pelvis image like here, the interesting part is of course in the pelvis. On demand, the user can switch on this green color, this green snow, how we call it, giving us an information where this automatic ranger process found region of interest. This is a process where the user does not have to go in. This is an automatic process in the background, and you see for the pelvis and here for the hand, the green snow is where it should be. Region of interest in the hand is in the hand. There are some possibilities of failure. The success rate of this ranger is what we think is round about 95% or even more. There are some critical anatomies where the ranger might fail, and I would like to come to this in a minute. The ranger works automatically in the background if the operator, the user, has this button on. This green light shows that the automatic ranger in the background is on. This should be the case in every system. If the ranger fails, as I talked before, it might fail in very few instances because we have huge metal implants or huge metal protection devices dominating the picture, like in pediatric pelvises, for example. Some anatomies are more difficult than others. A good example is patella, where an automatic ranger process really has trouble finding the region of interest all the time. In these very few cases, we have a tool for the user to interact with the automatic ranger and correct what might have been wrong. The user will see immediately if the ranger failed, even without doing anything, because the image that pops up automatically is much too bright or much too dark. So our rule of thumb is this: don't go into this ranger tool unless you see that the image is obviously much too bright or much too dark, and then, if this happens, don't correct this error by window and level. A lot of competitive systems don't offer this ranger tool, and in this case the user needs to go to a manual window and level tool and correct the image according to his or her own belief. This includes some dangers, because people will be doing this without talking to a radiologist, according to their own taste in the X-ray room, on a monitor that is not diagnostical, and with an ambient light that is completely different from the radiologist reading room. So it's a very bad idea to correct image problems manually in the routine work by window and level. That is the reason why we introduced this special tool. It looks like this. Here it's very visible, this image is much too bright. We simulated this error. What the user will do then is he will go into this tool, which is marked in blue now, which gives them this green snow where the automatic process shows what happened in the background automatically. And very obviously this is a case where I simulated a wrong ranging. Now, instead of using window and level tool and try to correct this manually, what the user can do is point with a finger or with a mouse into the area that is region of interest. Then automatically this happens, where the green snow is being corrected, the image is not bright anymore, and also the exposure index that I'm going to talk about in a minute is being set correctly. So, summary, we have a tool called Eleva ROI pointer, again region of interest. This should be used in those very few cases where the image initially is too bright or too dark, to correct the ranging, the segmentation, and to correct the exposure index without the need of using a manual window and level tool. This is a very powerful tool, and users should be trained about this. Showing all that, we have to talk about the exposure index now, a very important tool in every DR system. Why do we need this? Again, let me come back to film, where we had a very obvious correlation between dose and brightness. Normal dose was correct, brightness was much too bright in case the dose was too low. This happens in fixed mode, which is like what a film would do for us. Now in DR this doesn't happen, as you know, because in DR all the dose levels will give you the same brightness and contrast property. To make it more obvious for the user that still the dose was too low or too high, we have the exposure index. This exposure index on Philips DR systems based on Eleva is according to the IEC standard that you see here. This IEC standard is a must now, and every vendor should follow this. Our Eleva systems are following this standard already for quite a long time. We were almost the first one to implement this, and by now every vendor should use this, which means that this exposure index is comparable between vendors. Our implementation is we calculate this for the dose center, that means for the region of interest where the green snow is being seen. And the formula for it is this. The exposure index shows at RQA5, which is 70 kV plus 21 millimeter aluminium, at region of interest. It shows under these circumstances the microgray on the detector multiplied with 100. That means for our factory set, for example, which is a 400 film speed system, the target value for this exposure index ideally is 250. But again, the question to the customer is really, where do you see the correct range of your exposure index, because they might have a completely different opinion compared to what our factory set will do. And again, this needs to be in balance. Our factory set might be nice, but maybe not. If the customer says, I want to save a lot of dose from Philips, we should either talk to the radiologist and tell them that the image impression will change, or we give them a different image processing. If our target value is here, for example 250 for the factory preset, of course if this target value is not reached, not always we have to repeat. An example would be if the target value is like 250, but for this particular image we reached a target or a real exposure index of, let us say, 240. The question would be, should we repeat or not? The answer to this question is this little picture where you see the target value in the middle, and we see that on half of the target or on double of the target, images are still acceptable. But of course the level of acceptance goes down when you go to these borders. So 240 would never be a reason to repeat. 100 might be a reason to repeat. So we have an area within this picture that is very acceptable, marked in blue, where we would not recommend to do any repeat or any or to expect any problem with the image. Now here in this area, when we go closer to the lower limit, we recommend to check for the noise in the image, not necessarily immediately repeat this image, but check for the noise, look at the image very closely, and then decide on an individual base, do I have to repeat this or not? On the right side, we have an area where we would say the dose was really too high for this purpose, for this question, but don't repeat because the image will look nice. This is just a case of, let us call it, wasted dose for this kind of question, purpose and patient. On the very left side now we have real low exposure index numbers, where we would really say if it's below a certain limit, the user should really consider to repeat this image. On the very high side, we have values of exposure index where the danger of burnout effects, as we saw them before, is really getting higher and higher. And here the user should not look for noise, but should look if all the anatomy is there, and should check for burnout effects. Normally we never go into areas of more than 1000 in routine, and here we should really talk either about a technical or an operator problem. This should never happen. Also on wrong ranging, this should not happen. Example for the factory preset is this. When the system comes from the factory, we set it for an exposure index of round about 250, which equals to a 400 film speed system, which means the dose for region of interest is round about 2.5 microgray. Now if we see exposure index numbers between 200 and 300, we don't recommend to repeat this image at all. This should be a fine result. If we go lower in the dose, maybe at about 100 of exposure index, this would really a case where we should consider a repeat or at least check the image for too much noise. And 500 is a limit that we see. Below 500, this area again, we would call it unnecessary high dose. But this number, like more than 1000, is really a fixed value where the detector might go into the nonlinear behavior of burnout effects. When we talk about unique image processing more in detail, now as we know the exposure index, our latest technology and still state of the art is what people call multi-scale image processing. Philips, we call it unique, unified image quality enhancement, which gives us a multi-resolution image processing. That means it will enhance details of all sizes. It's non-linear. This means that we also enhance very much details that are so weak that they would normally be missed. And it's universal because we are using this unique image parameter for all our RUD products like the Dura Diagnost, the Primary Diagnost, the Digital Diagnost, our mobile and also our PCI Eleva. It improves image quality by bringing out all details, and again there are no artifacts. When you remember this image from the beach, this brownish artifact line, we come to this in a minute and we see how this looks like in a medical image. It integrates dynamic range reduction and harmonized contrast. This is a picture about the difference between unique and normal conventional image processing. And what we see in this knee is that first of all the details that are visible are quite okay in the conventional image processing, but here this black area around the implant is the dangerous area of edge artifact. This relates to this brownish line of the image of the beach, and here you see a black frame around the implant, which could be a medical implication. This could mean that this implant is getting loose because of an infection, but in fact if you look at the right image, it's nothing else but an image processing artifact. On the right side you see what we do with unique. The details are even better and the artifact around the implant is not there. Unique does not create artifacts like this if being used in a normal range. Here we see another example, normal image processing versus unique. Normal image processing would give you some details, the nasal bone, and here these details are quite visible, but if we go to unique, you see everything is visible much better. And the big strength of unique is that it creates a lot of detail visibility without creating these artifacts. It's a fine line from which on a radiologist would tell us this image is over processed, and the image on the right is an example where maybe half of our customers would say this is great, this is the best image I've ever seen. Some other radiologists might tell us that this is already over processed and showing so much and much too much, in which case we would just modify our unique image processing to show a little bit less information and make the image a little bit less, I would not call it aggressive, but a little bit less processed. This is a job that our application people are trained on and can do it within minutes. The technical implementation of unique is a multi-scale Laplace pyramid, as you see it here. From the image, from the original image, we derive different bands, different frequency bands. Here, for example, we see the high pass, and finally we have here the low pass picture. And afterwards we compose all these partial pictures together to have the final image that is going to send to PACS, and that's displayed on the local monitor. The user interface implementation is much more simple than this picture implies. In our user interface we don't show all these technical parameters. This is one of the big benefits of unique image processing compared to others. Our user interface is still medical and not technical. We are not giving out user interface names like enhancement of first subband, but we have user interface elements that might be called detail contrast, structure boost, density, gamma, and so on. And if you move one of these parameters back and forth, what actually happens in the background is that Unique will push and pull all of these parameters for you in the background in an intelligent way, so that the user still has an understandable user interface. One of the strengths of Unique is really that, not only the technical quality but also the quality of our UI. Also important to know for the end user is that this unique image processing is not a thing that they go in their daily routine. Really, the normal radiographer has nothing to do with this, because we from Philips, or maybe a super user, will align this image processing, and after that it will work in the background and the normal radiographer has nothing to do with it, which is a big benefit. So we from Philips handle it, and the normal user has no user interface. This is an important message for our customers, saying, relax, you don't have to handle it yourself. It happens in the background, we do that for you. We do this for you in our review. In our review, we reprocess the image according to the radiologist's taste. We talk to them, and afterwards we are setting a new image processing individually for this particular customer, which then happens in the background for the daily life of the radiographer. So our job is really, we translate the demands of the radiologist into technical language. We do that, and this gives us perfect image quality and ease of use, and this completes my presentation. Thank you very much for listening.